हाँ मैं क्लिक मैं लगा हो जाएगा फर्स्ट आप ही का तो भी कम करनी पड़ेगी ना।
हो गया यार, काफी देर हो गया।
Good morning to all of you, and welcome to day 2 of this pain workshop. We are starting because we are already 10 minutes late. We'll ask Dr. Ashish to start slowly. And because of this, we'll give him extra time, 25 minutes. So he has 25 minutes to give his talk, and those who are present here and those who are on live streaming can enjoy the nuances which he is going to teach us. Dr. Ashish, please.
Good morning, everybody. Today, this is a very important topic. It is very close to my heart. Can I have my slides? I'll jump into the nitty-gritties right away. So today, my focus would be on RF lesioning for trigeminal neuralgia. But if you're not doing it on a regular basis, in that situation, the understanding of anatomy is important, and I'll try to focus most on that. So I'll quickly skip some basic slides. Obviously, the gold standard even now is medical treatment to start off, and then we have ablative and non-ablative procedures. In non-surgical ablative procedures, the head of the gang is RF ablation, though we have balloon compression and glycerol is not too often used these days. And then we have the keyhole approach for microvascular decompression. So trigeminal neuralgia, as we know, is one of the severest form of pain, more common amongst females. I'll just focus on these red things. Can I have the laser pointer, please? Thank you. So clinching a diagnosis is obviously, as you understand, it's clinical, and you're not going to really get anything radiology. Many times we see that we are missing veins on the MRI, or we may not be seeing the vessel, but still the patient has neuralgia. So obviously, it's restricted to, it's restricted to the fifth nerve. The trigger point may bear no anatomical relation to the site of pain, but it's on the same side. Sleep is often not affected. That's very important. So the important thing is, one, angle of mandible. The pain will not go or should not travel below the angle of mandible. That's one. Most of the patients will tell you that my sleep is not affected. So it's more of a daytime sort of pain. So uncommon to have the sleep being affected, and there would be episodes of remission as well. So in medical therapy, you have carbamazepine and other drugs. We are all using them. In ablative procedures, glycerol rhizotomy, balloon compression, percutaneous RF, and radiosurgery. So alcohol has a high recurrence, shorter term relief. Balloon compression is excellent for V1 neuralgia, and it is quite comparable to, even RF, though RF scores higher. Radiosurgery, gamma knife, 80% relief at 1 year. Following failed previous procedures, this appears to be good. And recurrence is highest for the percutaneous procedure, for the non-surgical procedures. So let's come on to radiofrequency lesioning, and these are my personal indications. So failure of medical treatment, obviously you shift to some form of surgical procedure, but this is very important, and I respect that. Patient preference, it's extremely important. So, the books would say that less than 60 years of age, go for an MVD, or if there are a lot of comorbidities and or no comorbidities, go for MVD, etc., etc. But I think, we need to respect what the patient wants. It is our duty to tell him the whites and blacks and grays of the procedure, but ultimately we should allow him to choose, and we shouldn't sort of, tell him what we think is the best for him. Because all of these procedures have failures, be it MVD or RF or etc. etc. For aged and medical comorbidities, again, I tend to put RF as the first choice, and if there is a recurrence after previous MVD, it's the best for V2, V3 neuralgia. People have also started doing for V1 at a lower temperature. So now I'll try to focus on anatomy, and this is what I want you to sort of imbibe as well. Because if you understand the anatomy, then doing RF lesioning is a piece of cake. It's very simple, easy to perform procedure. So as we know, we have the trigeminal ganglia, and then we have the three divisions, and sort of here you have the foramen ovale through which the mandibular nerve is coming out, and from here we enter into the Gasserian ganglion. So how does the foramen ovale look like? On sagittal plane, it lies in the mid-pupillary line. Okay, I'll show you a few photographs of that also. And it is approximately 1.5 centimeters lateral to the internal canthal ligament. I'll explain what I'm saying here. Now, again, it is the level of posterior root of zygomatic arch. That is again one of the landmarks. But don't get confused. I'll just tell you the simplest of thing. Now, just see here you have the foramen ovale, and you can imagine the orbit here. So the foramen ovale on a coronal plane, on a flat plane, will be somewhere near the mid-pupillary line. Okay, so when you are putting the needle, just see to it that you are towards the mid-pupillary line, the success rate would be higher. Now again, if we look here, you have the foramen ovale here again towards the mid-pupillary line, but other foramen you need to see as well. You can injure the contents of foramen spinosum, foramen lacerum, and then you may as well injure the jugular and inferior orbital fissure contents. So it's quite important to understand that if you are grossly not on trajectory, then you can injure important structures. In foramen ovale, we have the emissary vein, same, the vein, nerve, artery content, but generally you don't tend to injure these smaller vessels. So it is this foramen ovale is almost 7 millimeters by 4 millimeters in the middle cranial fossa and anterior part of the petrous temporal. But this is a generalization. What my experience has been, as you get more and more older patients, so it might be tentatively easier in a 5th decade lady versus a 8th decade male patient, because I think there are a lot of skull changes still happening, there are a lot of ossifications happening, and the entry into the foramen ovale may become challenging. That's number one. Number two, again, it is not necessarily a ovale, though its name is foramen ovale, but it's not necessary that it will always be an oval structure. At times it can be really small, and you may struggle to find where the foramen ovale is. But this is sort of, in most of the cases, it is 7 into 4 millimeters. And again, if it is small in size, or there are a lot of osteophytes, or sort of entry is difficult, you can take various approaches, various views of your fluoroscopy to sort of negotiate the ovale. Sorry. So what you do is basically how you find the canal. When I say mid-pupillary line, so when your needle is entering, the trajectory has to be towards the mid-pupil. That's number one. So what you do is you insert a finger inside the mouth and you ask the patient to close the mouth, and then about sort of 3 centimeters lateral to the oral angle, you start your entry. Now you're putting this needle, your finger for 2 or 3 things. Number one is you don't want your needle to penetrate the buccal mucosa. That's number one. Number two, you're feeling the mandible because the needle. Third, you're also feeling the third molar, maxillary third molar, because the foramen ovale lies behind it. So sort of your needle becomes, your finger becomes your eye, apart from the fluoroscopy, to guide you towards the foramen ovale. So the current available techniques for cannulation, you have the traditional fluoroscopic guided, which I hope you would be seeing today. You can also do a CT guided cannulation, and neuronavigation guided cannulation is also possible, but then it's like taking it a little too high. So coming to ideal trajectory, 3 centimeters lateral to angle of mouth. Why we have decided on this, I'll come to it. You direct your needle medially. It is felt by the finger within the oral cavity towards the mid-pupillary line. And on lateral fluoroscopy, it is almost 45 degrees to the hard palate. Junction of anterior 2/3 and posterior 1/3 of hard palate, or a little behind. So I'll show you some photographs. So let your needle, this is your first guide, the hard palate. So when you are having a C-arm look at the hard palate and it's gonna guide you. And then it is almost 1 centimeter below the floor. Electrode positioning, we'll talk about it later. Okay, now relation of the foramen ovale with the hard palate, what I was saying was, see, this is the third molar area, and the needle is, and this is the hard palate. So when you see the hard palate on the lateral X-ray, the needle goes from somewhere in the posterior 1/3 to go there. If it is going more anteriorly, you may enter through the inferior orbital fissure into the orbit. Complication avoidance, early detection of the trajectory is important. Hard palate is a fixed bony landmark. It's going to help you. Provides estimate of trajectory in the early phase. So initially itself, you are guided by the hard palate. Later on, the sellar floor, clivus and petrous temporal area would help you. Lateral fluoroscopy is important for prevention of complications secondary to misplaced needle. So this is a study we are still continuing. I'll skip that. Okay. Now see this photograph, you need to focus. I'll explain you each and everything. So first of all, you should have a clear single anterior floor. You should have a very good view of the sella and the clivus. This is the petrous temporal. This is the hard palate. So your technician should be able to show you exactly this picture for you to negotiate the foramen ovale. First landmark is the hard palate, and the needle has to be in the posterior part of the hard palate. The next is sella, so sella and the petrous, and it is somewhere at the junction of the clivus and the petrous. That is where you need to target your needle. And mid-pupillary line. So these three, if you have, you would be able to put in your needle in almost 80% of cases without a lot of jugglery. Okay, in most of the cases, what I have just shown you, you will not require a AP or a submental view. Now, there are two schools of thought. One would always use a submental view, and the other group, say I'm one of them, I would try to first negotiate it only on the lateral. Agar ho jata hai to it's good. Otherwise, if I'm struggling, then I'll take a submental view to give me an idea where the foramen ovale is. So this is an important picture. So here you have the foramen ovale with the mandibular. Just behind and medial to it, you have the internal carotid artery. But because of the way the foramen lacerum and carotid canal is, it's not very easy to sort of injure it. and because your needle then starts getting into the petrous temporal, and you know that you don't have to go there. So chances of injury is remote, but still it exists if you are not cautious. And then still behind is the internal jugular vein. What you can really injure is the middle meningeal artery in the foramen spinosum, which is just nearest, but then you will not have major bleeding, because there are a lot of structures to sort of compress the bleeding. It is only rare that you will have a major bleed. Now, coming on to the X-ray, you need a good lateral view. You need a flat and without a parallax anterior cranial fossa, a good stellar position, and you need to see the clivus and the hard palate. And this is what your trajectory has to be. I'll just show you this photograph. This is a video with a 3D. I'll just orient you. So here we have cut the mandible. Here you see the third molar on the maxilla, and this is the foramen ovale. So we'll just try to rotate it so that you can appreciate. So your finger is going inside, and this is the space you get to sort of enter. And then this, if you look up, it is almost nearly to the mid-pupillary line. So this is on the left side, and if we rotate it, then you get the view on the right side. So I hope you've understood the 3D anatomy now of foramen ovale. If you want, I'll show this again. Right, then you should know where the location of the Gasserian ganglion is in relation to the other cranial nerves. So it is abutting sort of the cavernous sinus wall, and I haven't sort of injured or damaged the higher up nerves, but somehow one of my patients suffered an abducent nerve injury. Perhaps there was an abnormal location. So I did RF twice in this lady over a period of 5 years, and both the times she had eye complications. But other than that, you generally don't tend to injure these nerves. What you injure is the ophthalmic nerve, and also you can cause corneal hypoesthesia. If you look internally, this is the location. So you are entering from here. So the lowest you are in relation to the clivus, you will be targeting the mandibular division or the V3. If as you keep on going higher, you will reach to V2 and V1. And clivus is sort of your point. If you are sort of proximal to the clival line, you're targeting more of V3. At the clival line, you're targeting, say, around V2. And as you get in, you're targeting V1. I'll skip this. Okay, so this is the photograph I've again brought in. So as the needles keep on going inside, you're dealing with more of the divisions. Today we have one patient who has, I think, V2, V3, and another has V1, V2. So you would be able to appreciate that as well. So 90% relief immediate with a recurrence of 20% at 1 year is what the results are for RF ablation. So what I do is I use a 22 gauge needle, 10 centimeters of 15 centimeters, depending on the electrode that you have, the size of the electrode. You enter through the foramen ovale, the tip reaches besides the ganglia. You do a test stimulation, a paresthesia in the trigeminal distribution. And then you also check for motor stimulation. And then finally you conduct a lesioning of 60 to 80 degrees centigrade for 60 seconds. So you can do 1 or 2. I have generally, in my area, I have had much higher recurrence if I have just given 1. So I tend to give 2 shots, and my preference is 75 degrees centigrade. Why that is, I'll show you that as well. So you need a RF generator. There's a fluoroscopy, and you need a good anesthetist and team. A small Support in the interscapular area. There is mild extension, very limited. Oxygen is flowing. Your anesthetist is there with you. You position the C-arm. See that there is no parallax. The sella needs to be sharp. You need to see the clivus. You need to see the petrous temporal. You need to see the hard palate. So this is what you, the area of interest is, and you need to sort of focus in here. Now, on lateral view, you can either place the patient like this or like this, but it sort of doesn't matter till you see all your bony landmarks clearly. So I was talking about the lateral canthal line. So you can just sort of draw, and this is where you will enter, or you will take 3 centimeters lateral from the angle of mouth. Now, why 3 centimeters? Because you have the facial artery and facial vein very close to the angle of mouth. You don't want to cause a sort of a hematoma here. So that is why you tend to go more lateral. So you just mark it, and this 3 centimeters would almost be in line with the lateral canthal line. You give a local with a needle inside, again 22 gauge, 10 to 15 centimeters with a 5 millimeter active tip. Now you look at the needle here. You see this white thing. This is all insulated, and you see the black thing here is the active 5 millimeter tip. So you just need a simple insulated needle. On C-arm, you conduct this and you angle it towards the mid-pupillary line, and somehow you would be able to reach it there. Okay. Now this is the submental view, oblique submental view. So first things first, this is the foramen ovale here. It is in mid-pupillary line. This is the maxilla. It lies, so the third molar would be here. This is the mandibular shadow. So you just look inferior and lateral to the maxilla, and you will find the foramen ovale. But I must tell you, it's not that easy. At times you need a lot of movement of the C-arm to really focus on to finding, because there are other hypodense shadows that you see, and you tend to get confused. Okay, so the test stimulation is 1 millisecond pulse, 0.3 to 0.5 volts. Studies say that lower the voltage on which you get the stimulation, the less the temperature you can use, or the better results you will have. And paresthesia and the division of the stimulation sort of tells you. And here, when I'm giving the stimulation, there is movement, and as I increase the voltage, the patient starts, moving her jaws, because there's current traveling and there is some sort of pain. I'm just talking about the test stimulation. So you position the needle, and on an X-ray you gradually sort of take it in, and this is where you place. This is the clivus. Here the CSF is sort of coming out. Almost in half of the cases you will have the CSF coming out, but not necessarily in all cases. So you're very sure that you're in the right place. You introduce the RF cannula and you give the current. So the machine would show you the temperature, the impedance. Now impedance is very important, because if the impedance is between 300 to 500, you are sure that you are within the Gasserian ganglia. If the impedance is high, then either you are not in the right location, or there is a lot of sharding that has happened. So you may need to pull out your electrode, clean it, and insert it again. This is the temperature and the time. So here you have the stimulation, continuous lesion, pulsed lesion. Again, continuous lesion is what we are using. Pulsed lesion is not shown to have an extra benefit. Post-procedure instructions: antibiotic for a day, carbamazepine to continue, and you gradually withdraw, and you can discharge the patient 4 hours later. Complications: facial hematoma, injury to surrounding structures, meningitis, facial numbness, chewing difficulty, corneal hypoesthesia, dysesthesia, and these are the percentages. So more than 90% initial relief with good RF rhizolysis. However, there's 15 to 20% recurrence at 1 year, and at 5 and 10 years, it increases to 30% and 40%. Long-term results of MVD are definitely better than RF. Now, these are some alternative radiographic views. This is in some you have to do, so initially you have to bend your C-arm to 40-45 degrees and tilt it to 20 degrees to get this view. I'll want to draw your attention to the optimal radio frequency temperature and the optimal RFT temperature to achieve long-lasting pain relief with minimizing facial numbness and painful dysesthesia may be around 75 degrees centigrade. And our experience has also been similar. It gives 75 degrees centigrade is a good point at which you can target. Okay. So I've already talked about the complications. This is just more detail about it. However, in the interest of time, I'll skip this part, and yeah, I think I'll conclude my lecture with this. Thank you. Yes, sir, why not? Yeah, why not? I mean, if you are, it is ultimately there's a very thin, though not very thin, our buccal wall is quite thick.
Yes.
But still you can sort of injure, you can puncture.
You can puncture. So does that contaminate the needle? Do you have to change the needle?
Yeah, you can change the needle.
Yes.
But you can sort of, you can change it, clean it.
Okay.
Yeah.
Because the mid-pupil line, if you think like that, it comes inside the oral cavity in that way. Your needle.
Yeah, but what happens is buccal lining is coming and it is layering, it takes a turn,
right,
and then it's over the gums. So before it is taking the turn you're entering.
And the patient position in this we will be seeing in the OT, but it is patient is lying down.
Yeah, lying, supine.
Supine.
Unlike glycerol, where you tend to make him sit at times.
Okay, so here patient is absolutely supine.
Very. Yeah. It's a.
So patient is supine. There is no bolster, no nothing. There is no below.
No, just you push in a little bit of a sheet
sheet
under the shoulders
to slightly
just a little bit. But you can modulate that. What you want is a good X-ray picture.
And how do you define the catheter you have put in, RF catheter or whatever needle? You saying that first point is the V3, as you go in it will be V2. So you're deciding based on the paresthesia, or how do you decide where the end point is?
Ideally it should be both the location as well as the patient's feedback. Okay. So if they both match, you'll have the best of results. But at times, what happens is there is a miscommunication between what you want and what your anesthetist is doing, because your anesthetist is making the patient sleep while you are negotiating the needle.
Right.
And then when you're giving the test stimulation, the patient has to again awaken.
So you mean this is done under sedation, or?
Yeah, sedation. So I either use SIVO or I use propofol. So my anesthetist either SIVO or propofol.
Yeah.
Yeah.
Very nice presentation, Dr. Ashish. I have 3 questions for you. Should I ask one by one, or
Anything.
first of all, you told there will be a CSF coming out of the needle in 50% of cases. What I can make out from this is that means our tip of our needle is near the porous oculomotricus. Only then we can get because Gethering ganglion doesn't have CSF.
Yes. So
Should we withdraw the needle if CSF comes, or
no.
because the current won't be going into CSF rather than going into the Gethering ganglion, because the needle is hitting only the tip. And CSF can come only when the tip is in the CSF.
So what is happening is, it's like basically if you look at the ganglia, there are layers of arachnoid. So you really don't know how that arachnoid has been injured. Okay, so there could be a flow of CSF. So what you really need to focus is on the impedance.
Okay.
If the impedance is somewhere between 300 to 500, you are pretty sure that you are at the right place. That's number one. Number two is the current is like it's like elongated balloons. So the lesion. So it's not that the lesion is in a very small area. It's in a larger area. So sort of it will affect the ganglia.
Second thing, many times we give 2 cycles rather than 1 cycle. So do we withdraw or push the needle?
Yes. What I do is, one I give at, suppose there is V2, V3. So one I'll give at the clival line, and the other I'll just withdraw a little bit, do a test stimulation again, and then I'll give the RF.
How do you do it under anesthesia?
I do it under anesthesia.
How can you withdraw and then repeat stimulation?
Yeah, so for the next, again, the same process has to be repeated.
Remove the patient from anesthesia.
Yeah, so basically either we are giving a propofol or SIVO. SIVO, the patient comes out pretty fast. But
It just takes about half an hour for the patient to.
no, I'll tell you one more important thing. Why V2 and then V3? Because we know that V3 has much more motor stimulation, because the motor fibers are there. So even if I am getting a motor stimulation with little bit of propofol and SIVO, I am pretty sure that I am at the V3 area. So I go ahead. Even if the patient is not telling me that there is V3 paresthesia, I go ahead and I lesion it there.
Do you give anesthesia before you stimulate?
So I give anesthesia prior to stimulation, which is short. I get the patient, I push the needle in, because obviously that's a painful part. And then the patient sort of comes out, okay, and then I do the test stimulation. But as I was just, before you came, as we were I mentioned, there is always some sort of miscommunication, or that fluency is not there between you and the anesthetist.
Why we should not reach you?
Yeah.
Rotate it up.
Yes.
If you are pushing and pulling the needle in without confirming that you are in the right place, and you raise the temperature to 80 and you inadvertently knock off the V1, it's a total disaster.
So that is why, sir,
I'll
V1,
tell you what we do, what I do.
yeah,
We put the needle under local anesthesia. We don't give any sedation. So the most painful part is, of course, when you touch the.
Yeah.
So it's a matter of few seconds, reassurance, everything. And there is a vasovagal also, but reassurance is one. So you have to do the stimulation when the patient is fully awake, because he is not able to comprehend if anesthesia is given. So fully awake, you have to ask whether it is mandibular, maxillary, and make sure that it is. You go up to 0.5, 0.6 temperature, sensory stimulation. And if you are very sure, then only go ahead. Because sometimes what we have seen that you 0.5 motor 0.5 you're getting a sensory, but 0.6 you are getting even in V1, right? So obviously the position of the cannula also for maxillary is mid, upper in middle, and mandibular is lateral. So that also will vary. If you are very lucky, you may get mandibular, and then you push it down, you may get maxillary, but that does not happen very often.
yeah. So I'll counter this, sir. First of all, sir, for you, putting a needle and for us, putting a needle is a huge difference. You may be putting it in one go, so your patient may not feel that much of discomfort. When we are doing, we may be doing four points where the skull is touching, and that is a very painful process. That's number one. And number two, sir, I am withdrawing the needle, so I am moving away from V1. So that is, if I have targeted V2 and if I am withdrawing it, how can I injure V1?
That's okay. But when the patient gets SIVO or propofol, even when you withdraw, he is not able to comprehend that he is getting stimulation in maxillary or mandibular.
I would agree, and that is why I use a little bit of motor.
And you said needle in one go. See, the basic success of this particular procedure is seeing the foramen. If you are able to see the foramen, it's like a tubular, just go in.
I agree.
So if you are not able to see the foramen, I think we should not even attempt. So seeing the foramen is very important.
Yeah.
Our last question.
I also request Dr. Dureja to please come. He's the chairperson for today's session. So if you can just.
Yes, sir. During stimulation, do we get anesthesia or do we get the same pain which patient was having pre-op?
You can have either.
Okay.
You can have either, but generally paresthesia or pain, तो उसको मतलब he has to tell you something.
No more questions. We have the OT. Oh, we have the OT session.
Right.
Okay.
Thank you, sir.
To all of you.
If the speakers can talk there.
I'll keep quiet, sir.
10 minutes talk, 10 minutes.
ये नहीं है वो कहाँ मेरा ये ना I think Dr. Ashish has nicely covered all the relevant anatomy and fluoroscopic views, different views. So I'll straight away go to the procedure itself. While speaking on percutaneous microballoon compression, it is one of the safe, effective, and quick way to have ablation of the trigeminal ganglion, but unfortunately it's an underutilized entity, and especially this type of ablation is very effective in patient who have involvement of V1, okay, and the patient who doesn't want any intervention in awake patient, okay, they want good sleep while doing it. In those patients you can use safe use. And if patient have multiple intervention, like number of times he has intervened this RFA ablation, so those patients can be effectively treated with this. And one of the most common indication of these is post-herpetic neuralgia, especially involving V1 division of the trigeminal ganglia. Coming to how it's different from other procedure, is the same as other ablative, especially RFA, glycerol rhizotomy. Basically, it's a compression by balloon, and it preserves the ganglion cells. And compression causes ischemic injury, but there is differential injury of axon with superior trigeminal ganglion cells, and that suggests that axonal regeneration possible, and that may contribute the recovery of motor and sensory function in due course of time. And histological studies have found that the injured areas have higher number of surviving small axonal fibers. So that there is a selective preservation of unmyelinated pain responsive fibers that seems to opposite to the other ability procedure that injure these fibers. And there is a selective preservation of unmyelinated pain responsive fibers seem to be a live goal for the pain treatment, as I told you. And balloon compression relieves trigeminal pain by injuring the large myelinated axon. Those axons are related involving sensory trigger. And unmyelinated pain fibers mediate nociceptive pain transit, but they are not the source of sensory trigger. So that way, that is different from the other ablative procedures. It's a simple and effective procedure, usually in multi-division involvement. I told you, especially using ophthalmic division involved. It does not injure myelinated fibers which mediate the blink response. So can we safely use venous division involvement? It's especially useful in patients who have communication problem during selective thermal rhizotomy. Most time I use general anesthesia. The people in literature said that people use in local anesthesia also, and monitoring very important, especially those patients can have trigeminal depressor response that have severe bradycardia, and some patients may have HST also. So you have to be careful. You have to keep the restriction drugs, defibrillators to be standby, and as it's a CM guided technique. We usually use heart rate technique that is described
by Dr. Ashish also. In those procedures that we utilize anatomy landmark and fluoroscopy arm views. The position is supine. And one has to be careful there to be unnecessarily hyperextension neck has to be avoided. And 3 landmarks we use at point of entry needle, like 2 to 3 centimeter related to the external this angle of mouth, then mid pupillary line, and 2-3 centimeter from the mid-zygomatic area. And we utilize direction depth technique at every insertion, like 5 millimeter or 1 millimeter. We check the different views, lateral views and EP views. And one has to be cautious not to breach the oral, because as Dr. Ashish has described, as regarding this RFA and this position, basically we never insert the needle under sedation. We, as Dr. Druja has told, that we use only local anesthetic to insertion needle till we have lateral view. And if you see this, we keep the needle like this and slowly insert and see the patient response. If patient is having some pain or some paresthesia, we usually counsel that patient, reassure. If even that patient is not cooperating, then rather than midazolam or propofol, I use fentanyl, 20 to 25 more. And after waiting for some time, insert the needle. And how we decide what is the end point of the needle? This is the pituitary fossa, this is the clivus. Where the clivus meets the process part of the temporal bone, that is the junction where we should aim this. And if you draw a line from base of the pituitary fossa that crosses the clivus, that's the end point. You should not exceed your needle insertion above this area. That means you are near the ophthalmic division. And at 5 millimeter above that line, that is you are at the V1. 5 millimeter below this line, that means you are the V2, and another 5 millimeter, that means you are near the V3 division. We go with it. And then final is patient response. We estimate and ask the patient where she is feeling the paresthesia or pain. Similarly, and what is different in needle position in PMBC, we never go above this area. Okay, we try to keep the needle tip at the wide bore needle. We usually use 14 gauge needle. We keep the needle here and insert the catheter, and catheter has to be just above that line crosses the clivus. Say 2 to 3 millimeter above this line. I'll just come to that. When we started, I think we started this procedure in 2010, when we started this patient that internationally, that Cook's PRBC kit used to be available, but that was not available in India. So we made some stopgap arrangement. We utilize this type of needle. This is the needle, 14 gauge needle. This needle is basically used for insertion of spinal cord stimulating lead. Okay, and we use this Fogarty 4 French catheter for conduct of this. Nowadays, this kit is available. This is around 35 to 40,000 kit. It has got all the things and has a pressure monitor also. To start the procedure, I always take AP view first. And if you look at the AP, this is not the AP view. And AP view, I try to keep the petus part of temporal in the inferior part of the orbit. That is a true AP view. And I tilt for some interval till this, you can see this mandible, maxilla, and this is some mental arch. Unless you have this area, this is a bone-free area, then usually a 20 to 30 days submittal is more than adequate. And once you have that area, then you slightly have a oblique view. You rotate the C-arm ipsilaterally and have, the focus is always this. You can see this foramen. It should be always, if you divide in 4 quadrants, this should be always in the upper quadrant. And as you can appreciate, in this area there is no bone. So you can simply use the tunnel view. You can After this, I always use 2 to 3 centimeter later to the external angle, and I always use tunnel view. If my, especially in RF ablation, if I am planning to do ablation of V3, I always keep the needle lateral or middle if you are planning to use V2 or V3. And for PMBC, I always insert the needle in the middle of the foramen. Sometimes there is an article by Brown that says if you take it's a true AP view. Now you can, this is the petrous part of the temple. If you appreciate the middle part of this, in middle aspect, there is slight dip in the petrous part temporal. That's the area where Meckel's cave lies. If you keep the needle laterally, that means you are trying to ablate the V2. If in the middle of this, that means V2 or V3, or medially for V1. As you can appreciate, the tip of the needle is not crossing, not more than 2 or 3 millimeter above the foramen well, and directional window is the point where clivus joins the petrous part of the temporal bone. After asserting that my needle position is okay, I insert the catheter. Initially, we used to use that ureteric catheter to make a tunnel so that we can insert the catheter safely. But over a period of time, we found that there is no need of making any tunnel or channel. You can simply, most of the time, once the patient, you can simply insert the Fogarty catheter. As you can see, the tip of the catheter is just 2 to 3 millimeters above the point where the clivus meets the petrous part of temporal bone. These are balloon shapes of, once we have confirmed that my tip, balloon tip, this catheter tip position is okay, we try to inflate the balloon with, we take 1 ml of radial contrast material, and this has to be by continuous fluoroscopy technique. Initial picture, then after starting the inflation with radial contrast dye, this is, then ideal position is this. You can see that the nipple is coming out, and that shows that nipple is going towards the porous trigeminal. That's the ideal. That's the ideal position, so that you can have a good compression of the trigeminal ganglia. Coming to different pictures, if you overinflate, the you can have a dumbbell shape appearance, dumbbell position, and this is more or less ideal position for having ideal compression, tear shape appears. As I told you, that ideal position is this, 2 to 3 meters above the Meckel. We can see that it's just 2 to 3 meters above the point where clivus joins the petrous part. And just to say few words, that catheter should be porous as it compresses the retrogressive fiber against the form as the dura and petrous raises the tool switch, allowing now to pass in the Meckel's cave. If proximal to porous, if you inflate the balloon proximal to the porous, then the balloon itself lifts the ganglion from the dura and no effective compression can be made. So always you should have a nipple shape appearance so that part of the catheter balloon is in the porous trigeminal. These are various shapes one can. This is dumbbell. This is not effective. This is also not effective. Partially effective. This D is the best. This is going to the cranial fossa. This is also not required. This is another dumbbell shape. So ideal is this small clip. This is how we start the procedure. We usually use anatomical language for initial purpose, then we follow the fluoroscopy guidance totally. And while inserting the needles, as patient is anesthetized, there is no need of giving local anesthesia. And before starting, always check and always keep a finger in the mouth so that needle tip won't breach the oral mucosa. Once you stabilize the needle, say 2-3 centimeter, always go for some fluoroscopic use. Because you can say needle is going towards the mid-pupillar line and mid-zygomatic area, and that needle insertion itself is 2 to 3 centimeter lateral to the angle of the nose. As you can see in this view, now just enter the foramen ovale. I will just stop here, and that after confirming the position, I started inflating the balloon. Now, once you have a pear shape, you keep the compression to initially it's described around 90 seconds, but I keep usually 120 seconds. And after this compression, but during compression also the patient can have trigeminal depressor response. So we have to be careful. Those patients have cerebroidic, and in some patients we have encountered a systole also. And some physician recommend use of pacemaker or keeping the defibrillator ready for this patient, because in one of our patient we have a systole, we have to resuscitate the patient, but the patient comes out very well. And once you have made good compression, you have to remove the whole of the equipment, catheter and needle in toto, and give a good compression at the insertion site for at least 5 minutes, so that there is no hematoma formation in the face. Time is over. Can I have 2-3 minutes? And regarding pain relief with duration of shape and balloon, as I told you, the pear shape had maximum relief and good outcome. And this sensitive ulcer compression pear shape, it has good compression result in good pain relief in most of the patient. And avoid the balloon too much in, otherwise, especially if you are having dumb bell appearance, that means you are going towards the cranial fossa. Regarding pain relief, that is most important. And in our study, in our case series, we found that 99% of the patient have immediate pain relief. The moment you shift the patient to the ward, and once the patient come out of anesthesia, they take it patient. They are having good pain relief. And in most of the study, the pain relief is more than 94%. And as any of the percutaneous transfemoral technique, this patient can have some complication, especially paresthesia or sensory loss in the face and masseter weakness. Coming to masseter weakness is around 70%, 60 to 70% after percutaneous balloon compression. I think this is maximum in this procedure. And some patients may have hypoesthesia in the face, but usually these things resolve out between 2 to 3 months the patient will have. Thank you very much. Delete कर देना है.
Sir, no need to.
A 4 French catheter that usually maximum you can inject is 0.7 as recommended in the 0.7 ml. Yeah. But you usually use 1 ml. We have done a number of occasions. You can simply use, if you are using fresh catheter, you can simply use 1 ml. And 1 ml you have good shape, unless there is an anatomical variation of the buccal shape. So most of the time you will have a pear shape with 1 ml. Pardon? Pressure we don't have any equipment, but nowadays we are having this usually 1.3 to 1.2 neutron. But in most of the cases we have not monitored. We go by pear shape appearance of this and keep 120 seconds. And the moment you start compression, inflating the balloon, the patient usually, in around 80% of the patient have trigeminal depressor response. They have cerebroidic, unless you are careful. But in literature, people recommend the use of atropine, prophylactic, but we don't use it. If you have trigeminal depressor response, that is confirmed that we are at the right place. So if you have cerebroidic, just deflate the, and then you can give some atropine and later on reinflate the organ. Mhm. 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 Now, actually, in APU, if you see, if you bring the petus part of the temporal bone in the inferior part of the orchid, and if you follow that petus part of the bone, there is a slight dip in the middle aspect of the petus part. That anatomically suggests it's a beginning of the porous trigeminy or Maxwell's cave. If you take this, and we have in RFA also, we have injected some dye also and seen the spread. And if you are using lateral view, if you use that where the clivus transect the this part of the temporal bone, you should not exceed 2 to 3 meter above this line. But that means you are near the ophthalmic division, or you will be bypassing the porous trigeminy. So maximum, say, if you draw a line from the base of the pituitary fossa to the clivus, okay, that's a line which should not exceed for V2, V3 division. Okay, if you another 5 millimeter below that, that means you are near the B2 division, and if you are another 5 millimeter, that is 1 centimeter, that means you are at the V3 division. There is another law. Some people are recommended where the clivus joins the transect the petrous part of temporal bone. You should always insert the needle 2 to 3 millimeter anterior to that cross line. Okay, and if you make that area as a 12 o'clock image a circle, okay, for 10 centimeter, that means you are going towards the V3 division. For 11 and 12 position, that means you are going towards the V2 and V3 division. Mm. 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 Pardon? Mm. Dr. Saini is one of the pioneer of triangular ablation techniques.
Surgery and started doing it. But it was very expensive and we are getting the huge one and sterilizing and everything. We did not do that because it was not really available in India. They have all got the cardiac lab. So we gave up in 1985. A friend of Saini was the first person who started doing this all
So, very first study that was published in literature from India is by Dr. Nataraj from RML Hospital. He has published 60 patients of percutaneous balloon compression in early 80s. And Hmm.
Yeah. You are in a 500 cases.
So we have seen, we have been under guidance of Professor Dureja, but he used to do RFA and all that. Thank you. Thank you.
When we are discussing,
I'm inviting
first to be ready with the slide.
Dr. Navdeep Sokal for his talk.
So, good morning, everyone. And today we are having a very wonderful weather in Delhi. So, hope you have enjoyed. And now we are enjoying the very good academic feast. And I will congratulate all the organizing committee for this. So, we will be discussing maxillary and mandible blocks for trigeminal neuralgia. Though both these divisions can be taken care at the gastrointestinal ganglion, but there are other approaches also where we don't want to enter the gastrointestinal ganglion, but we tackle these little bit lower and with other approaches. So as you can see here that our face is very richly supplied by the various nerves, and most of the sensory supply is by the fifth nerve, but rest also contribute like 7th, 9th and 10th nerve. And as you come to know that the fifth nerve like V1, V2 and V3. So extraoral route we don't ablate V1, but V2 and V3 we want to ablate. So first I am going to discuss maxillary. So anatomy is very important for whenever we are discussing about trigeminal nerve and its branches. And one thing I want to tell you that whenever you are doing any manipulation with any of the trigeminal nerve, the monitoring is most important thing, because the TCR may be a complication and it may be disastrous for the patient. So as you can see here, so this is trigeminal ganglion, this mandibular nerve coming out of foramen ovale, this maxillary foramen rotundum, and this is ophthalmic for the superior orbital fissure. The maxillary nerve is a pure sensory nerve that begins at the gastrointestinal ganglion and travels anteriorly and inferiorly along the cavernous sinus through the foramen rotundum. So this is foramen ovale and the blue one is foramen rotundum. So again, this is really important because in trigeminal, if you don't know the anatomy, it may be difficult. So this is the trigeminal ganglion. Then it's the maxillary nerve comes through the foramen rotundum. Then in the pterygopalatine fossa, where it gives most of its branches, like pterygopalatine nerve, which supplies the nose and palate. Then the zygomatic nerve, which further divides into zygomatic facial and zygomatic temporal. Then it gives the posterior superior alveolar nerve. And the infraorbital nerve, which travels through the inferior orbital fissure and comes out infraorbital foramen and gives further branches. So we mostly try to ablate this in the pterygopalatine fossa, and territories, as you can see here, the lower eyelid, the ala of the nose, the cheek, the upper lip, the cutaneous zygomatic and temporal area, and it supplies superior teeth, the palatine bone and maxillary bone and maxillary sinus. So what are the various indications for the diagnostic and therapeutic management of trigeminal neuralgia? As a adjunct to GA, for the major cancer surgery to maxilla, ethmoid sinus, maxillary and infratemporal fossa. In children, you can have wonderful postoperative analgesia if you give bilateral maxillary block for the repair of congenital cleft lip and palate. And in maxillary trauma and maxillary osteotomy, the block may be used. So along with the long needles and syringes, if you are doing pulse radiofrequency, then the 5 active tip is desirable, and local anesthetic and neurolytics can be used. Neurolytic, we mostly use 6% phenol and 40 to 50% glycerol or absolute alcohol. So first, I am describing first infrazygomatic. There are two approaches for the maxillary: infrazygomatic approach and suprazygomatic approach. So first, what you need to do, you need to identify mandibular notch, and you can ask the patient to repeatedly open or close his mouth. And keep your finger in the just at the mid-zygomatic bone, and when the patient will clench his teeth, you will feel the notch there. This is between the condyloid and corneal process. Then the needle is placed just perpendicular to the skin as a posterior inferior aspect to the notch, and needle is advanced till you touch the lateral pterygoid plate, which will be at the 4 to 5 centimeter. Mostly this comes at the 4 centimeter. Then the needle is directed anteriorly and superiorly towards the root of the nose and advanced in the pterygopalatine fossa until a paresthesia is obtained. And it is always important to obtain paresthesia because it increases your rate of success. So if you are just blocking it, up to 5 ml of local anesthesia injected, but if you are using neurolytics, then just 1 to 1.5 ml is enough. And for the, if we are using the pulse radiofrequency here, the sensitive stimulation of the 50 Hz, 0.2 to 0.5 volts, and motor stimulation the 2 Hz, 0.6 to 1.2 volt. Somebody may ask that this is pure sensory, then why? What is the role of motor? If there is motor stimulation on the maxillary, then you may guide the little bit just forward. And the pulse radiography is done at 42 degrees Celsius for 2 to 3 minutes. The same procedure can be done under fluoroscopic guidance. Here you first go in the lateral view and reach the superior one-third of the pterygopalatine fossa. And in the epi view, we confirm the depth. The needle tip should not cross the lateral wall of the nose. There are complications of this technique that you may puncture the maxillary artery, the posterior pharyngeal wall, the submucosal abscess may be there. If you go through the superior orbital fissure, there may be orbital injury which may range from ophthalmoplegia to the complete blindness, and you may enter the subarachnoid injection may be done if you are too deep. The other technique is suprazygomatic. This is again landmark based technique. So our entry point is just above the suprazygomatic arch and the posterior wall of orbit. The needle is inserted perpendicular. Then it is advanced to reach the greater wing of sphenoid, which will touch 1.5 to 2 centimeters. Simply in the temple area you advance and the sphenoid bone will come. Then you withdraw the needle and go in the posterior and caudal direction, as you can see here, and advance till you reach the pterygopalatine fossa and you negative spread for blood and find paresthesia, and then you need to inject the drug.
Thank you, Dr. Raji. And
the same procedure can be done USC guided also. Here the landmark is anterior is maxilla and posterior is sphenosinus, and this is pterygopalatine fossa. In the base of this pterygopalatine fossa, you see the maxillary vessels lies, and maxillary vessels lies ventral and inferior to the maxillary nerve, and the needle is advanced using an out of plane approach. So the needle is so this is the position of the probe. This is placed in the infrazygomatic area, and the real-time ultrasound guidance allows direct visualization of the internal maxillary artery, identification of the needle tip, as you can see here is going, and the spread of local anesthetic solution within the pterygopalatine fossa. Then the terminal branch of the maxillary nerve is infraorbital, and which comes out of the infraorbital foramen, and it's also for giving it again is divided into 3 nerves: the inferior palpebral, the lateral nasal, and superior labial nerves. So it supplies the skin and mucous membrane of the lower eyelid, the cheek between them, and the lateral side of nose. And this can be simply blocked at the infraorbital foramen, which lies in the midline of the pupil and just 1 centimeter below the orbital ring. So next is mandibular nerve block. This is the third largest nerve of the trigeminal, and this is only mixed division. The rest two are only sensory, ophthalmic and maxillary, but this is motor as well. The motor root arises directly from the pons. It doesn't come from the gisant ganglion, but it carries with the mandibular nerve, and both divide just after the foramen oval, just coming out of the foramen oval. So the gisant ganglion. So this was foramen rotunum, this is foramen oval. It goes like this. Then it gives its motor branches to both the pterygoids, medial lateral pterygoid, then masseter and deep temporal. And then the sensory are the buccal nerves, temporal and buccinator. And other important the auriculotemporals, the lingual and
just 30 seconds.
Inferior alveolar nerve, which acts as a mental nerve, literally. So this mandibular nerve supplies the ipsilateral mandibular bone, the lower teeth up to the midline, the buccal and lingual hard and soft palate, anterior to tongue of the anterior 2/3 of the tongue, the floor of the mouth, external acoustic meatus and auricle of ear in its anterior zone, the skin over the jaw, the temporal area except the area of the angle of the mandible. This is not supplied by the mandibular nerve, which is supplied by the superior cervical plexus.
Okay.
So indication as the non-malignant chronic conditions like trigeminal neuralgia, the vascular neuralgia, the post-herpetic neuralgia, patients with cancer or trauma, and surgery on the lower lip or anterior 2/3 of the tongue. So preparation is same, and the monitoring is must for any trigeminal block. So pulse radiofrequency can also be used, and position is supine. And if you are using C-arm, the patient to be placed in supine position, and we first use in lateral, then AP view. So surface landmark is same here like the maxillary. We are again using the mandibular notch here, but what we do, we just enter the skin perpendicular to the mandibular notch. Then we advance to the infratemporal fossa with the lateral terminal plate serving as a bony endpoint. And the depth is usually at the 3 to 4 centimeter, mostly 4 centimeter. And then for the maxillary, we advance it to superiorly and anteriorly, but here we advance it posteriorly and little bit inferiorly. And then we see the paresthesia, or we can see the mandible elevation twitch. The minimal intensity of the stimulation may be around 0.2 to 0.5 milliampere. And then 5 ml of local anesthetic injected. If you are using neurolytic, again the 1 to 1.5 ml. And the neurostimulation is associated with high success rate. When we use motor twitch, there will be twitching of the mandible. The complications are again because this is mandibular now, and you may enter either in the mandibular artery or the maxillary artery. There may be injury to pharynx if you are going a little bit posteriorly. So intermaxillary and middle meningeal artery can be injured if you have inserted the needle too high in the mandibular notch. Injury to pharynx may be while walking posteriorly of the lateral terminal plate, because just posterior of the terminal plate, if you go more posteriorly, you may hit the superior constrictor muscle of the pharynx. And the large volume of local anesthetic solution, the nearby nerves like facial nerve paresthesia may be there. The other complications which are maybe sometimes really dreaded, the prolonged vertigo and ataxia after mandibular nerve block, maybe if you injure the auditory tube while going through the pharynx. Sometimes transient asystole, as Dr. Mohan was telling, that due to trigeminal cardiac reflex, patient may go in asystole and CPR may be needed. So these blocks are really very risky, and a good monitoring and anesthesia help should be there. And sometimes we have seen one case of mandibular displacement when there is pain, there is serious spasm of same side of muscles, and to maintain the neutrality of the mandible, the other side of muscles also go in spasm. As soon as the pain was relieved for that person, the other side of muscles pulled the mandible out of the mandibular notch and the mandible was deviated. So pain on the same side was relieved, but then there was pain on the other side. So this was later sent to the dental clinicians, and they fixed the jaw. And this is another this terminal branch of mandibular nerve, that inferior alveolar nerve, which comes out of the mental foramen. This emerges at the mental foramen and divides into 3 branches, and this supplies the labial mucosa of the lower lip, gingiva, and the skin of the chin. And the same thing can be taken with the ultrasound guided also. So there is supraorbital foramen, infraorbital foramen, mental foramen. These all lies in the mid-pupil plane, and with the USC guidance, you can see that there is dip in the bone. So I think, and you can simply block this mental foramen here. So thank you. Yes, sir. Yes, sir.
They will put an hand. I have several tooth extraction. I know how they put it and how effective it is.
Yes, sir.
And mandibular block is very commonly used by dental surgeon for extraction of the molar, any tooth.
Yes, sir.
That is very
So they give
maxillary nerve directly pierce the hard palate directly, and they don't block maxillary nerve, but for mandibular nerve, for lower jaw, they block it.
So dentists mostly use the intraoral blocks, and we use here mostly extraoral because both the techniques are described, but we mostly use
They
extraoral.
must be doing several blocks of mandibular.
Yes, sir.
They very successfully they block the mandibular nerve. Okay. Any other question? If there is no other question, give me a big hand. Very nice.
There is no hata.
So we thank the speakers and the chairpersons of this session. And now we'll break for tea. We have a lot of operative cases lined up, as you can see in the schedule. And we'll come back here at least in 20 minutes. So by 9:40, we should all be back. Thank you.
Hello. Hello. Okay, sir. हेलो हाँ अजय जी हाँ जी हाँ ठीक है ओके ठीक है हाँ जी हाँ जी वीडियो में राय सर माइक से बोलना एक बार हेलो 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 गिरीश जी जी 1 मिनट में ओटी से चेक करा रहा हूँ लैपटॉप की ना हेलो राय जी हेलो राय सर आपकी आवाज नहीं आ रही अरे यार अभी अभी करवा लो जो करना पागल हुए चलो क्या आ जाऊंगा
ऐसे कैसे कहोगे मैं तो गया हूं। और क्या जाओ
अभी बात कर लो
हमें बात कर रहा
हेलो माइक देखिए कैसे चला अरे तो हम खुद को पड़ेंगे हेलो डॉक्टर हेलो अनुज ये सर ये OT-1 जैसे केस का लिखना लिखिए केस भी लिखना पड़ेगा हाँ सर वो बना रखा है पता है ना कौन सर्जन है ये देखो हाँ ठीक है ये पहुंच को देखा OT-2 में
वेट करेंगे। चेंज कर रहे थे।
अनुज क्या हुआ माइक का?
माइक चेंज कर रहा था।
ओके।
हेलो राजेश सर। हाँ जी बिल्कुल क्लियर सर। बोलो।
4 नंबर है।
हेलो
हेलो हेलो हाँ गिरी जी।
हाँ राजेश जी।
हाँ जी हाँ हाँ कौन?
हाँ जी
आवाज
सर।
आ रही है?
हाँ जी सर।
ठीक है।
हाँ ठीक है।
भाई तू नीचे कैसे यार, तू तो ऊपर होना चाहिए।
सब बस ठीक है सर, डॉक्टर साहब ठीक है। ओके।
हेलो
दूसरी ओपी में करा दो आप।
हेलो
ये हेलो
हेलो
हेलो।
यस सर।
हाँ जी सर, आवाज आ रही है आपकी।
ओके है
ठीक है, बढ़िया वीडियो
बढ़िया।
बढ़िया सर।
ओके
अब वो दे दो दूसरा, तीसरी ओपी।
हेलो।
हाँ ठीक है।
हेलो
सर दो ही ओटी है।
ठीक है सर, दो ही ओटी है ना?
यस सर।
ठीक है, थैंक यू सर। ले जाएगा ले जाए।
टेम्पो में डलवा दो। किसके?
Hello? OT-1? Hello?
Hello, yes, sir.
OT-1, be ready. We'll be joining you in 5 minutes. Delegates are having breakfast. Maybe in 5 minutes we'll be ready to join you.
Okay, sir.
So by that time, be ready with your presentation. Sir has reached. Hello? Okay, sir. Okay, sir. Sir, we'll join you in 5 minutes, sir. Thank you, sir.
For this session, we have
This MRI was done from outside, sir, and there was no loop visible on this MRI imaging. This MRI was done from ends, this was repeated from ends, and there was an aberrant vascular loop of SCA seen compressing the left trigeminal nerve, sir, in this external
can you
component.
go back to the MRI?
Yes, sir.
Can you use your marker to show us the aberrant loop?
Is this coming?
Left side or right side? Abhishek?
So it was on the left side, sir.
So please, there we can see the.
I think
Yes.
this is the loop, sir.
So we can see on the lower scan, we can see clearly the artery,
Yes, sir.
which is there, vessel loop. Okay. Carry on.
Sir, now this patient is planned for RFA, sir.
So Dr. Dureja is there.
So supervisor sir is there.
So Dr. Dureja, sir.
Okay, can you hear me, please?
Yes.
Okay, fine. So you can see that we have positioned the C-arm.
Can we just increase the volume of Dr. Dureja?
Okay.
Anuj,
Volume.
Ravinder.
ठीक है. Ravinder, volume बढ़ा देना. So now you.
Yes, sir. Yes, sir. Now we are
So
good.
yeah, we have now sort of positioned the C-arm so that we can see the foramen of veil very, very clearly, because I think the success of your procedure depends on the visibility of foramen of veil right in the center, just 2 to 3 centimeters away from the labial fold or the lip line, and position the patient a little bit of hyperextension, and you can see patient की position दिखा दो. We hold the head so that while doing the procedure it doesn't move. Sometimes while touching this area, the patient gets a trigger and he gets a very severe pain. So you have to alert the patient about it. And also, as I said, that we do basically under local anesthesia, and then once we have reached the ganglion, then we give after eliciting stimulation, motor and sensory, then we give anesthesia, which is like fentanyl, midazolam, and propofol. Okay. You can keep asking questions, please, till the patient.
Sir, just when will you give the anesthesia, sir? The fentanyl midazolam?
After I have stimulated the nerve and found out that this is a V3, so I am going to go to the V3, and when the patient is sure and I am sure that I am at V3, then I am going to give anesthesia for the ablation, because ablation is pretty painful. So as Dr. Mohan was also mentioning in the morning, that when you enter the foramen of veil and you touch the ganglion, you may have a trigeminal reflex, which is bradycardia, so you've got to be careful. And we have atropine already ready with us in case of any emergency. We also tell the patient that this will be momentary pain, so bear with us, because after that the stimulation part, he has to be cooperative to tell us that yes, he is.
Actually, you can show the machinery how it was made for the material. You want to no, just show the position, zoom out the
So it is not a full view. So can you please
zoom out? They can move the here.
the source is not visible, only the receiver is visible.
Can you show the whole thing out? Only the receiver is visible. Yes, sir. What is it here, sir?
So if the impedance is more than 500, what are the ranges? This is sensitive to me.
We'll just increase a little bit. बढ़ाइए सर कहाँ आ रहा है जी में आ रहा है सो मैनिपुलर डिवीजन लिंगुअल ब्रांच फोर्थ पे आ रहा है नीचे वाले बोर्ड पे तो सिर्फ कान तक जा रहा है कान तक और बढ़ाइए कहाँ से कहाँ तक कहाँ से हो पर जी so we are covering that so we are getting a very low stimulation that way we are right just around the curve or just few millimeters away from the curve right so then is that okay for everyone yes so then the second is a motor because V3 is a motor nerve, so you may elicit some motor stimulation because it is supplied by masseter. So we start with the low current. So for the motor, you are reduce camera please. Yeah, reduce it to 2 hertz. बस कोई बात नहीं, इधर पेशेंट के चेहरे पे रखिए। या थोड़ा सा बढ़ाइए।
Yes, sir, we can see the tweeting.
You can see it. ये तो कैमरा में आपको कमाल का है, नीचे दिख रहा है, मुझे नहीं दिख रहा और दिख रहा है। थोड़ा सा और बढ़ाइए सर, थोड़ा सा मुंह खोलिए। हाँ, yes. So just tell the patient to open the mouth so that you can see this classical stimulation.
The stimulation, yeah,
You
the
can. So
twitching is seen.
again, this is at 0.12. So this is acceptable if you get it up to 0.30. But 0.12 is that means we are very close to the nerve. So you need not go to higher temperatures above 80 degrees would be good enough.
Yeah, the camera is focused on the radio frequency generator.
Radio frequency generator, 415 impedance, good. 0.12 is the stimulation, 12 volt is the stimulation, 2 hertz is the frequency which we use for motor, 1 second. And at this we are getting a good stimulation. Camera here please, you are getting good stimulation. ठीक है जी, इस क्या ये बंद हो गया, ठीक है। अब just to confirm, because I'm a little suspicious guy, I really want to confirm again and again, because this has to be a full proof and we extend stimulation once again. बस वेद प्रकाश जी एक बार और करंट दे रहे हैं, आप बताइएगा क्या आ रहा है। कहाँ से कहाँ तक, कहाँ से कहाँ तक, और नीचे और बढ़ाइए, यहाँ जीभ में भी आ गया, ठीक है। So that completes our stimulation and now we go for the correction. So now is the time when we go for the sedation. So we give Miracula 250 ml and propofol.
Guruji sir.
जी sir.
Sir, the motor stimulation is less than 0.2, 0.3.
Yeah.
So do we need to moderate the load a little bit so that the motor weakness is less? Do we need to?
No. Because if you are doing V3, you have to get it. So you will, in any case, you are going to knock off the motor part of this. So you can withdraw, but still you can't spare the motor division. Even if I withdraw, I can't spare it. I will not go to higher temperatures, maybe 80 is the max. Otherwise, sometimes I will go up to 90. But motor will be definitely knocked off.
Okay, sir.
There are other muscles which help in mastication, so masseter going is not a big issue. So you can now see the C arm, the position of the needle. C arm, दोनों दिखाना please. दोनों view दिखाना. एक C arm के दोनों view दिखाइए. C arm, वो वाले. दोनों वाले दिखाइए, दोनों. So this is the final confirmation. Because we are getting it at very low stimulation, I am happy with it. And we have started anesthetizing. Oxygen is already on flow. We have given fentanyl and Miracula, and now we push in propofol.
Okay, sir.
How much? बताओ. हाँ. सुनते हो. बेहोश कर रहे हैं. सुन नहीं बेहोश.
The anesthesia protocol may be enumerated.
So anesthesia protocol is good anesthesia, fentanyl 50 to 75, sometimes even 100. Some sedation, Miracula, and knocking off with propofol. Propofol will give up to 20, 30, 40, 60, depending upon the patient tolerance.
Sir, Dr. Dinesh here.
Yeah, Dinesh.
Sir, can you use local anesthetic here?
There is a blood and CSF coming in. I will not hit that.
If it is not CSF,
I will never do that. I don't want to introduce anything into that area.
even if it is not blood or CSF?
See, if it is a very high risk patient and the cardiac abnormalities and all, I do use it, but generally no, I would not recommend that. We use Zyclocar, which is preservative free, 0.2 to 0.3 ml, but with this CSF and other things, better to avoid it. So he is anesthetized now, so we can start the stimulation. Udhar Daniel, please.
Sir, one question.
Yes, एक एक्सर सर प्लीज स्टार्ट है आप हो गए अगर ज्यादा होगा तो और प्रोटोकॉल देंगे स्टार्ट चलिए स्टार्ट थोड़ा प्रोटोकॉल और दे
So you set the temperature at 15
what is the protocol I start with 50 60 seconds 60 60 seconds 70 60 seconds 80 60 seconds that's it
And you do one or you do twice?
80 or do twice. So it's okay. We don't produce deep anesthesia. It's okay. Oxygen is on. Keep a watch on the saturation. My ears are always hooked on to the monitor. Before anybody else recognizes bradycardia, my ears would. It's like 45 years of listening to the monitor. Yeah.
What do you do if there is a bradycardia, sir?
That's it.
That's stop the lesion?
No, not need to stop. The bradycardia will only happen once you enter the problem and touch the ganglia. Otherwise, there won't be any bradycardia. So we have gone to 660 now. The second lesion is at 60.
So needle you are not touched, we are just making 2 lesions.
This is the second lesion now.
Second.
Neither I am not touching because I am getting good stimulation, so I don't want to touch. And he will get up absolutely pain free. So although some people say that it takes 1 week, 2 weeks, but the real success is that patient gets up without pain, and he would never have that same pain again. The duration of relief would be from 3 years to 10 years.
So what is the dial doing, sir, on the output control dial? What is that?
Output, this output is coming up depending upon the impedance and depending upon the temperature and all. This we are not controlling.
Okay. So the dial only controls the temperature.
We control the temperature and that's it.
That's it.
So this is 60 degrees. Then we go to 70. जो लिफ्ट करनी है तो कर सकते हैं. ठीक है. 70. So we're going to 70 now. Third lesion. So these 5 minutes changes the life of the patient. From that severe episode of it's called suicidal disease also, to absolutely no pain. And I think it's worthwhile for everyone to learn this and practice this in their cities. Yes. So if nobody is asking me the complications, yeah. So the complications like immediate would be infection, but this is the only procedure where we give a prophylactic antibiotic. So I will give it monocyte 1 gram immediately, and after the procedure I give paracetamol IV infusion for the relief pain which generally occurs, and continue antibiotic for 5 to 7 days. That is one. And give an NSAID also because sometimes the pain of this procedure can last for 2 to 3 days.
Okay.
The other complications are generally seen these like if you are doing V2 particularly, and if there is a little bit of a normal of V1, then this hyperesthesia or keratitis and all those things, if the V1 is involved. So while doing V2, you're going to be more careful.
How frequently can you repeat this procedure, sir?
This sir.
How frequently can you repeat the procedure?
Sure, as long as the patient comes back to you after 3 years, you don't repeat it. Generally, they won't come to you for at least 2 years, 3 years, 4 years, sometimes even 8 years. So whenever they come back, you have to do it. But at least compared to the alcohol block, which generally lasts for 9 months to 1 year, this lasts for a pretty longer period.
Okay.
So do you recommend for the beginners to start with V3?
Yes, agree. Yes. V3 is the safest and the best way to learn. V2, hold on for a while, do about 10 V3 and then go for V2. Chaliye sir? Sir? 80 seconds now. So this is the last repetition of 60. Yeah, that's okay. That's fine. That's his concern. Then he was secretion. So this is the fourth lesion, sir. This is the fourth lesion, last final lesion.
So normally you will create 4 times positioning.
No, like 50, 60 seconds, 60 seconds, 70, 67, 80, 120 seconds. Total 5 minutes.
Rare increase in the
Yes, yes, always. It is less painful for the patient because you knock off at 50, the next lesion is less painful, knock off 60, less painful. So, but you have to wait for some time if you want to really have this effect.
But generally, sir, like if you have already lesioned it for a couple of times,
Yeah.
sometimes there is a risk that the tip might get some tissue which can get.
That is only at high temperature. If you're doing at 90 degrees, then there may be charge of the tip of the needle, but not at 60, 70. There is none whatsoever. So it's comfortable now. Waiting, up for here. हो गया He is a smoker.
Can you focus on the patient?
Yes, sir. So I'm taking out the needle now. दिखाइए sir. Taking out the needle and just giving a pressure. इस पे pressure डालो. Yeah, दिखा दीजिए. Wait, आँख खोलो. ठीक. He is a smoker, so there is a little bit of secretion. Yeah, do it. So any question now?
I think we are clear, sir. Thank you for a nice demonstration.
Thank you.
Any other questions from the audience? If anybody has some.
Sir, as you told this discussion that you need to be in the lateral part for the mandible and middle part for the maxillary.
Yes.
But here we were but in the middle actually. So it is necessary to go there or sometimes middle between it.
No, if you look at the foramen, I am more laterally. But yes, you can get it like as we were discussing in those lectures. The first part is the V3, then you go deeper in, you get V2. That may not be a classical thing which you get it. But if you are laterally, if you are needle placed laterally, you will definitely get V3. If you are in the middle, you may have to struggle. In the middle also you get V3 first, so you may have to go in to get V2. So this is not hard and fast, but as a rule, laterally, mandibular, middle, maxillary, and medial is V1.
And sir, if we need to do the V2 also in this patient, then what will be our strategy?
So that's what I was discussing, that now I have to pull him out of anesthesia, and after maybe 1 hour, when he's out of anesthesia, I have to reinsert the needle. That's the best way to do it. But as I said, that initially supposing it is both the division, while stimulating, I can push the needle in and see whether I am getting the stimulation in V2. This is like a practical tip, but this is dangerous step because once under anesthesia, you don't know how much distance you are going. Obviously, you can take a lateral view and fix the position of the needle and then go back and take a lateral view and go there. But because your stimulation will not be successful at this, so it is little dangerous because you may have now reached the Weber. So that is the only flaw. So to pull the patient out of anesthesia, Reggie, so he's out of anesthesia. So after half an hour, maybe I can do the procedure again to go for V2. That would be the best approach.
And sir, one last question. Does the aggressive CSO makes any difference to the RF procedure? Means CSO is one procedure means other CSO in other procedure there is no CSO, but there is there.
Yeah.
So does CSO make any difference?
No, that doesn't make any difference.
Okay.
Thank you, sir. We can shift to OT-2 now. Hello.
Yes, sir. Okay, you are connected, sir.
Yeah, Deepak, we are all ready. We are
Can we increase the volume of Dr. Ashish?
Hello?
Yes.
Yeah, I am audible?
Yes.
So let me show you. We have already introduced the needle patient position. We just have to do the stimulation. So I will give more time now. The reason is we just have one machine and as of now. So we are using it in both the OTs. So to begin with, I want to share that this should be
The camera will be focused on the X-ray monitor.
yes, Ashish. So this needs to be flat.
Right.
Then you have a good cellar at the climax.
Right.
So first things first, see the location of the needle in relation to the heart palate.
Right.
On the lateral film, it is either in the posterior 1/3 or behind it. That's in here. The next important thing you have to observe is the location of the pincer petrous temporal. So where the petrous temporal meets the clavus, just almost about 4-5 millimeter above that is your foramen ovale and entry. So truly the entry is here, where the clavus come anterior portion toward the sphenoid sinus is sort of merging with it.
Right.
So there you enter, then you reach to the clavus. Okay. Now, I'll show you the oblique view which sir was just sharing.
But you usually do in the lateral view.
I use most of the time I'm very comfortable doing just the lateral. So here you see the foramen ovale. This gentleman, he has trigeminal thoracic pain in V3 and V2 for last 2.5 years. Severe spreading toward the posterior part of the head as well, above the ear and a little behind that as well. And now the medications are not working. On MRI, basically you have vascular compression on either side, but obviously he has the left-sided problem, so we are doing it on the left side. And here if you see, this is the mandible. Here is the third molar, you can see the foramen ovale. You have to find the maxillary sinus, just lateral to it you will find it, and this is almost mid-pupillary line where you are going.
Right.
Now, the position of the patient is very important. There is mild extension, but the important thing here is when you are doing a lateral X-ray, sort of you have to see that it's all parallel. So first, what I do is I break the parallel nature. Abhi shoot kijiye. Okay, now look here.
Yeah.
If you look at the clavus, though they
Camera focused center image. Yeah.
आप थोड़ा सा इधर नीचे की तरफ लाएं, हल्का सा.
Now you can see.
Yeah. So if you look here, you are not able to see the clavus very well.
Right.
Now have a look. अभी एक shot लीजिए. Shot लीजिए. So all this is not good for you. Shot लीजिए. All these images don't नहीं ऐसा. हाँ अब कर. You appreciate now?
Yes. Yes.
So now we are like back on and we are ready for stimulation. What I am using currently is stimulation कर लीजिएगा 50 hertz. 1 millisecond with we'll start with a voltage of 0.3.
Camera can be focused on the generator.
So actually the patient is sedated.
Yeah.
You are giving.
Patient is not sedated. Button has just injected some amount of fentanyl, and because I was able to get it on first pass, so we did not sort of require.
Right.
Take short patient. Yes, this is all just about. It gives you a basic idea. That's about.
Can you focus on the machine, radio frequency machine?
Shoot, please. Okay. This location to begin with.
Okay.
चलो अभी स्टिमुलेशन करना प्लीज ऑन कर. और बड़ा बड़ा ले जाए. आप तो तेज तो नहीं होती. बड़ा ही 0.3 तक ले जाए. हाँ ओके. नाउ स्टिमुलेशन ऑन कर. नहीं 0.3 ऑन. नहीं you have to switch something to on. ओके ओके. अभी आपको कुछ लग रहा है? वैसे ही कलर आ रहा है. Okay, so he confirms that he is feeling the same amount of pain.
Right.
So और उसी जगह पर आ रहा है. हाँ ठीक है. So now little bit of it. And आप 75 degree will be taking. Now we'll give RF of 75. No, this is high. Okay, and for 60 seconds you can Switch it on. Yeah. Give it.
So, which hub we have targeted here?
You are targeting E3, right?
Right now we know. So as I told you, I tend to go to the higher dermatome first.
Right.
And then, so he's having pain. And I'm giving the current, he's moving and he's having pain. Which sort of confirms.
So you don't give any kind of sedation or
Stimulation, sort of, either I give, quickly finding the foramen and the patient is having a lot of problems.
Sir, you are not going to do any motor stimulation?
I do for P3 now because once he's sedated, for P3 I will show you that.
So, in
For 60 seconds.
Sir, just a question, not actually good question. If you resume the D2 first and then come back to the D3, as Dr. Gurita was saying that probably the lesion effect will be there and you will actually appreciate, is that...
Yeah, so for that, you just need to increase the stimulation voltage. So instead of 0.3, because right now we got at 0.3. So if it is not coming again, we give it at 0.5 or 0.7. And also I look for the motor stimulation at this point of time.
Okay.
Next step, please. Next step, please.
Why this X-ray again, sir? Okay.
X-ray, please. Yeah, like this location looks pretty good to me.
Okay.
Are you able to appreciate all
Yeah.
So I fire the stimulation at 0.5.
So you always do perform single lesion.
75. So the there's a difference between this machine and yeah. So he is already started having pain again. Can you appreciate?
Yes, sir.
Yeah. So stop it. Continuous with जाएंगे. So we have got a good stimulation at 0.5.
Right.
Yeah. So as you see, we can easily get it, and there is a lot of mixing. We'll do a 75-degree again. 75, yeah, start. You have to give. अभी आप अच्छे से दे सकते हो.
So do we are not doing the motor stimulation here?
Yeah, so he was mixing and a lot of motor activity. Now, you know, there's a difference between this machine and the one that I have, it's not continuous stimulation. Sorry, Shivkumar, bus. So in that, there is a point stimulation. So when I push the pedal, and that point there is stimulation. So I'm able to see the jaw.
Okay.
Like I've also shown in my clip that the lady's jaw was opening when I was giving a test stimulation.
Right.
Yeah, everything was same. So we do something in reverse. Get the patient ready, and we just have one machine. Now Ravi and Datta, they sort of pulling out the needle, we'll demonstrate. Instead of putting in.
Demonstrate what?
Like how okay, the position of the. So come to this side. You also come. So I'll remove the electrode as of now. So this is the electrode. I am not sure what size sir used, but we have here a 15 centimeter needle and the probe. So we have used that one. Now, still at least, sister?
This you have got, this is your own?
No, this you have. But the problem was, these guys are compatible
and he has severe pain, he might just bite your finger off.
You can put a mouth gag and then do it. That is more safer.
No, you don't really require it. Okay. Okay. एक X-ray shot लीजिए please. हाँ. Okay. Now धीरे से pull back करना about say half a centimeter, and then we'll show them. हाँ. Shoot करिए. Okay. So this is where the foramen ovale is typically there. Okay. जहाँ पर needle का tip है.
Right.
Okay. Now we are pulling it further. If you look down below, it is just crossing the posterior part of the mandible. The hard part. Now pull it again. Now what Danta is doing is he is feeling the needle just lateral to the buccal mucosa. You are feeling the needle, right? थोड़ा और pull करो बाहर. Yeah, pull it further. Shoot please. Shoot please. हाँ निकालो और निकालो. निकालते shoot. हाँ निकालो और पूरा निकालो. So he has just gone there, and I want you to feel the third molar, and I want you to feel the mandible pura, and just locate where the needle is. You got it? Okay, so I am asking him to feel the third molar. If you appreciate on the X-ray, see we have just gone lateral to the third molar. Lateral में आप लोग को दिख रहा है?
Yes.
Yeah, so there is also an element of psychological dependence of all these drugs. Like we saw what Deepak was presenting for pregabalin. Similarly, there is a little bit of oxcarbazepine or carbamazepine group as well. So it is better to gradually taper it off. And as far as your question is, I would say around 50 to 60% of my patients, I really don't have a hard data, but I am assuming that about 50 to 60% of my patients are totally off drugs, and the rest may be on minimal amount, mostly SOS basis.
Dr. Ashish, do you use baclofen in any of your patients?
Ashish, the question is, do you use baclofen in any of your patients?
Yes. Is very potent, but then as you are well aware that lamotrigine has a lot of dermatological and other side effects, and it has to be really gradually increased vis-a-vis the other group of drugs, which you can sort of increase a little
minutes के लिए number 1.
Okay, Ashish, we'll have to interrupt you.
Sir, 42 minutes, sir. Just for 2 minutes, I wanted you to show my patient limited cesarean MRI.
Yes.
And he is there for that now. बताओ भैया कैसे हो? कैसे आप डर रहे हैं? हाथ लगा के देख. पहले क्या होता था? पहले लगता था. हाँ, हाथ लगा. ये ले. अब कुछ नहीं है? खुश है? ठीक है, सुन है थोड़ा सा सुन है. थोड़ा सा सुन है. सुन है. So, when we are asking about parameter, see, if you have done a container, I have to stop parameter. So, immediately reduce it down to 100 milligram and after 15 days, we never call anyone anymore. After 15 days, they stop parameter. And till the pain on that, they don't order us. They should not order us. ठीक है भाई? Right.
We can have second case in your OT, sir.
Yeah.
Or Rajiv told me that you felt it was unsuitable for.
Yeah, I am not
Right.
Right, thank you. Sure.
Sir, when we can expect a peak effect of this?
Dr. Dureja, one question is there.
Peak effect after RS?
When can we expect the peak effect to come, sir, for this?
See, normally you know the return is immediately, like what you see. But yeah, sometimes the practical initially, but the thing and there will be a pain will not come back after the there might be some cause or either even themselves say without part with compound your second and slowly and steadily within 2 weeks.
There should be an immediate relief, maximum.
Right.
So we immediately shift the patient with after a couple of hours we send the patient back home.
Right.
Sir, our patient has been called to OT, sir. Our patient is being shifted there. Okay, sir. My next patient is Somati, sir, a 45-year-old female. She came with complaints of low backache relating to left lower limb since last 1 year, sir. Increase in last 4 months. She has now new onset neck pain relating to left upper limb since last 1 week. There is no history of trauma, ball and bladder involvement and any claudication, sir. On clinical examination, her bulk tone are normal, sir. Power is 5/5 in all the 4 limbs across all joints. Reflexes are 2+, sir. Sensory examination is normal. On MR imaging, patient has cervical straightening with small central C5-C6 PIVD and central disc at L4-5 level and the right paracentral disc at L5-S1 level. Sir, our patient is currently planned for cervical root block now and will be planned for decompressive surgery, lumbar decompressive surgery for L4-5, L5-S1 PIVD, sir.
Can you show the imaging properly?
Haan, sir.
Cervical and then you show the lumbar also.
Sir, this is the imaging. Axial.
With lumbar.
इसको zoom out.
Lumbar angle.
Abhishek, where is the cervical axial?
Sir,
Axial cut.
sir, axial cut was not available, sir.
Sorry?
Sir, axial cuts were not there, sir.
Patient. So please arrange.
Yes, sir.
Patient is having the cervical MRI.
Yes, sir.
Show the get the films from patient and show it by putting on the V box.
Okay, sir.
Show us the lumbar also.
She has got lumbar MRI, sir.
Show us the lumbar.
Lumbar films you show lumbar axial.
Yes, sir, I'm showing, sir. Sir, this is a lumbar MRI, sir. She has disc at L4-5 and L5S1 level. So zoom out करना.
Where is the disc?
Zoom out.
And what about the complaint of related to the lower limb?
Sir, she had low back ache relating to left lower limb since last 1 year, sir, and it has aggravated since last 4 months, sir. But there is no history of claudication and bowel and bladder involvement, sir.
This patient we have planned for lumbar discectomy, but pain.
So, just that's why I wanted to know what is your at what time you decide the patient should go for discectomy? How will you decide? Because normally, if you say the patient doesn't have any significant motor involvement.
This one we had kept for both cervical plus lumbar, but sir feels block won't help her. This should be operated. This is planned for surgery, but we wanted her to give both pain relief for cervical plus lumbar. But Dr. Dureja says ki lumbar no need for pain, directly go and do surgery.
Okay. That's
In those cases we can go ahead with blocks. That's why she was kept. Yeah. That's why she was kept for.
Sometimes the patient waiting for the surgery also because the pain.
Yes. Many times many times these pain procedures help you in buying time.
Exactly.
Like patient is not ready for surgery because of some function or some official commitment.
Exactly.
So in those
At least
cases,
in our setup we have
it's
seen
OPD basis thing. You can just go and have it in 2 hours, and patient can continue with his routine life. So in many times it helps in buying time.
Obviously.
Yes, sir. Side. And many times, sir, when there is a disc is not that prominent, where it's not a clear-cut surgical case. In those cases, it helps in breaking the vicious circle also. And those cases get many times after breaking the vicious circle, pain relief is there. You rehabilitate them by physiotherapy and all, and many times you are able to cure him without any further treatment. Abhishek, patient taken on table.
The patient is coming, sir. She has not reached OT yet, sir.
What about OT-2?
OT-2 खत्म. ये लॉक इसको निकाल लो. OT-2 का करेगा.
नहीं पेन है मेरे पास. Abhishek, who is there in OT-2? There is a question from the delegates. What is the role of hyaluronidase? Is there any role of using hyaluronidase along with steroids when we are giving the root blocks? Dr. Navdeep, can you comment on this?
So, mostly when we expect lot of fibrosis or the previous surgeries, then we more use the hyaluronidase to break the fibrosis and for the better spread of the steroids for that purpose.
Okay.
That evidence.
Failed back syndrome case. Yeah. Okay. Another question is what should be the acceptable impedance in RF medial branch block? Like it was around 400 to 500 in trigeminal. So is there any such guideline for RF medial branch block? Up to 700.
Because there we are near the bone, so the higher impedance is acceptable.
Another question is should we dilute the contrast while doing the radiculogram? I think it's no, we should not dilute because we need a hyperbaric solution there.
Actually, during adhesiolisis, sometimes you may need because later on because you are using so much of dye and all. But in normal transforaminal or epidural, because you are using hardly 1, 2 or 3 ml.
0.2 or 0.
No, no, in lumbar epidural or transforaminal.
Okay.
In transforaminal, obviously, you are using a smaller volume.
Yeah.
Just see the how much contrast you are needed for reaching that nerve root or DRG involvement and the
It's
epidural.
usually, I think, less than a ml.
Less than ml if it is not
So then no need to dilute it.
So in that case, it's obviously it is seen better.
But sometimes we have used with the double dilution of the dye,
Okay.
and the only advantage with that that it easily clears. So if you need to reposition the needle, then you can see the needle tip. So sometimes you may double dilute the contrast agent.
So what are those cases where you want it to get cleared earliest possible?
So suppose if we the dye spray is not proper, and if we want to repositioning of the needle, then the needle tip will not be visible if the contrast is not diluted.
But you have already given it.
No. The contrast we have given,
Uh-huh.
and the dye spread is not optimal.
Okay.
Then you have to reposition the needle to get the spread in proper way.
Okay.
So for that, sometimes the diluted contrast may come help, but otherwise you can and as you perfect the procedure, you may not need to dilute the dye.
Most of the interventional
Hello?
in spine,
OT-1 back with you, sir.
so we hardly use
Just a minute.
maximum
OT-1,
4 ml.
you are connected.
Dilution is important if you are anticipating a large volume of dye to be used, like in visualization.
Okay.
ठीक है, field back surgery. So it's better.
Camera on the MRI, please. Camera on the MRI.
Thank you. Yes, Abhishek. Yeah, we are there with you, Abhishek.
Yeah.
Director, we are there with you.
Okay, fine. So we just have a look at the MRI imaging. Anybody can show the MRI? Yeah. So this
Cervical.
yeah, cervical. So she has a left-sided radicular pain, and you can see the disc bulge, which is causing pressure on the left-sided root. सीधा करो, सीधा करिए, सीधा करिए सर सीधा करिए, दिखाइए, शूट मारिए, दिखाइए.
Yeah,
So
symptoms on the left.
she has severe symptoms on the left side.
Left side is more.
Yeah, दिखाइए सर. Yeah. So we like yesterday we saw a cervical epidural where the nerve compression was more on the right side. This time it's the left side. Dr. Rajiv, your conference has become international. we have a delegate from UK.
Yes, sir.
He's a dear friend, and he's an alumni of All India Institute of Medical Sciences way back in 1980s.
Thank you, sir. Thank you. It's all because of you, sir. We owe it to you, sir.
So I welcome Dr. Praveen Kalia.
Yes, sir.
Sir, please enlighten the level which you selected and how.
So we are going at C6 and C7. This is what? No, C7 and T1 level. Right? You can see on the C arm, we have given local anesthetic as per the interlaminar space on C7 and T1.
Ravinder, please check the sound quality. We are not able to hear clearly. It's blurring.
So the two things which we require is a epidural needle, 2 His epidural needle, 18 gauge, and a special loss of resistance syringe. Right? So we have already given local anesthetic. Any sedation given, please?
Sir, this local anesthesia is given in the skin, subcutaneous tissue, and in the interspinous area.
Yes, interspinous area.
Okay, sir.
Please shoot. Shoot. Yeah. So you can see now I am going midline, but I will redirect it little laterally on the left side. Shoot, please. Yeah. Now you can see. Again, shoot, please. So you can see the position of the needle. I am on the left left epidural space.
Yes, sir. This is slightly, this is exactly in the midline, no sir?
It is going from the midline but to the left parameter.
Yes sir, from
Left gutter.
entries from midline and you are going on the
Yeah,
left side.
yes, yes.
Okay sir.
This is not a paramedian, so I am just gentle push to the plunger. Now I have reached the ligamentum flavum.
But even if you are in midline, still it can go, the drug can still go.
Yes, it can.
Yes sir.
हिलेगा नहीं.
So you are not going to check with the lateral X-ray, sir?
We will, but the only thing is that big breasts and shoulders. So I have already reached there. You can see the loss of resistance. I have reached there. Okay. So from sudden these things which I was showing, now I can push my air easily. Okay.
Yes sir.
So final position, please. Final position. Yeah, this is the final position. Now comes the die.
So many times on lateral view we are not able to see it. Then
Yeah,
what
I
is the
will-
solution in that case?
Yeah,
How you confirm your?
Can we
depth?
take the lateral view, please? So the die is on the preferably on the left side. I will push some saline to see the nerves, but before that I am हाँ दिखाओ थोड़ा सा अपनी तरफ लो ना सियाम अपनी तरफ हाँ और अपनी तरफ लो yes yeah you can see now the drug in the left this is the epidural space. You can see that you can appreciate the epidural space.
Yes sir.
And the roots also.
Yes.
So I'll push some more dye to show you.
Okay sir. And how much deep to posterior spinal line we can go, sir?
Deep means like you got to pierce the ligamentum flavum and enter into the epidural space. दिखाना, ठीक है? Right. So you can see the drug in the epidural space.
Yes, sir.
Bathing the nerve. So I will now give some saline to delineate the roots. You have to be very gentle when the needle is there.
This is saline, sir.
This is saline. We don't put any local anesthetic in this.
Okay, sir.
Check please. So you can now see both the roots, both the sides. I'm just turning the bevel on the left side and pushing in more dye. Check please. Yes. So just to complete, I will push a catheter which will preferentially go on the left side. This is the catheter into the cervical epidural space. Yes. So you may irritate some nerve while pushing this catheter, and patient may have some sensation in the upper extremity. Okay. So we put the dye. Show please. Now you see. Now I'm going more. Yes, it is going into the left upper roots also.
Yes, sir.
Pushing
Till what level it's going up, sir?
It's going up to C5 now. Show please. No, it's going a little higher up.
And
also.
where is the tip of your catheter, sir?
I'll just show you. Can I have some more dye?
Does this catheter has tendency to penetrate dura and go inside?
No.
On pushing?
This is a very mild catheter. No, it cannot.
Okay.
The one which we showed, the Rax catheter, which has a steelette can, but not this one. This is a very pure, very
soft
flexible
catheter.
plastic. Now show please.
Okay, sir.
Show please. Show. कैथेटर दिखा सकते हो? नहीं, कोई रेजिस्टेंस नहीं, कोई रेजिस्टेंस दिखा? या यू कैन सी यहाँ पे ऊपर दिखा ना, और ऊपर जा, हाँ, या ये these are the roots which you basically see. मैं वो तभी दाई डाल के दिखा रहा हूँ, आप दिखाना शेखर. Yeah. So this going up to C4 now. So our target is C5, C6. So we are bathing the nerves beautifully on C5, C6.
Yes, sir.
So then comes the time to give the drug, which is 8 milligram for 80 milligram of.
How much drug? How much and what drug you have given, sir?
I am giving triamcinolone, and it is 80 milligram.
Okay. Are you mixing local anesthetic also in
No, 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 not in the cervical level.
there? Okay, sir.
As I told you yesterday that it
Yes,
can
sir.
block the motor nerves. So going easily.
Is there any role of controlling the speed? Means it should be given slowly or
This is a fantastic question. Actually, I've been doing a study on the speed of giving the drug, because if you push it, it will go into the epidural space.
yes, sir.
So if you give it slowly, it is going to bathe the nerve, which is our final target.
Yes.
So that's why you can see I am not being very aggressive. I'm going very slowly. There's no resistance, but I'm going very slowly, so deliberately, so that it covers the entire nerve. And that's why we don't push a lot of saline also after this. Just clear off the catheter, and that's good enough.
And one more thing,
Sure.
sir. This catheter you have inserted inside, it's having only one hole at the tip, or there are multiple
No, there are
holes also?
multiple holes. There is no hole at the tip.
Means
Rather-
along the whole length, which is there inside
Yes.
the interspinal canal, the whole area will get the drug.
Yes, I will show you the catheter when I take it out. But
Okay,
I
sir.
wanted to show you the C arm now.
Ji, sir.
Can someone point the nerve root at C? आगे इधर नहीं left side. ये यहाँ से nerve ये the whole thing. Yeah, these are the roots. नीचे आ जाओ. ये this is the root. Yeah. So that's why we abandoned cervical root sleeve block. We rely only on the epidural, safe and effective. So
Sir,
some
in
of the
all-
drug,
Sir, in all of your cervical epidural, you use triamcinolone or in
No.
any case dexamethasone?
no, I don't use dexamethasone. I use either this or I use depomedrol. I use depomedrol.
So dipomedrol is also there. If you want to use, it's there available in OT.
Okay. So I use depomedrol, but I thought there would be a lot of eyebrows raised at depomedrol, so I'm using triamcinolone.
It's okay, sir. Whatever is your practice, please continue with that.
Okay, okay. But I think I'm finishing now. Yeah, so putting some saline.
This is saline now, sir.
This is just saline to push the drug. Again, check on the C arm. Please check on the C arm. Yeah. Now you can see right from C2, C3. I'll just show you. This is C2, C3, C4, C5, and C6.
Okay.
Through a needle placed on the left epidural space. Patient has left-sided symptoms. I don't want to waste my drug on the right side, and I'm achieving the spread of the drug in all the roots in the left side.
So total around 4 ml, of saline we have injected.
And,
Any times you have felt any epidural cord compression in such cases? Any
Not
time in
really.
your life?
No, not at all.
Okay.
So I'm just showing you this catheter. आप दिखाएंगे जरा इसको. So this is like from the side. It is never from the tip.
Yes, sir. We are able to see,
you
sir.
are
Yes,
able to
sir. We are able to see, sir.
So there are
Multiple side holes.
three, four holes from
Yes,
where
sir.
the drug is coming.
Tip is, I think, closed.
Tip is closed.
Yes, sir.
So the tip is very blunt and closed for the
soft.
same, for the reason which you asked me.
Yes.
It doesn't puncture, but you have to be careful. So
Thank you, sir.
thank you so much.
Thank you so much, sir.
And thanks a lot, Rajiv.
Thank you so
I have
much, sir.
finished my quota. I'm going back. I really enjoyed it. I'll come and meet you for 2 minutes. Thank you
sir.
so much. The
Thank you.
audience,
Thank you.
lovely audience, loved it. Thank you.
Thank you, sir. Thank you so much. Hello, OT2.
Hello, Dr. Ashish, sir. You are connected, sir.
There is a question from the delegate side. Dr. Pankaj and Dr. Ramesh can answer this. Is there any experience of doing this surgery post injection? There are reports of high scarring and dural tears post injection whenever we do disc removal due to dural thinning. Dr. Pankaj, can you comment on this? I'll repeat the question. Is there any experience of doing this surgery post injection? As there are reports of high scarring and dural tears post injection.
I didn't have any experience about this because we directly go for surgery. We usually don't send patients for. Now we will send patients.
Yeah, okay. Probably we'll gain this experience very soon.
I think.
But what does
again,
the literature says? Any idea?
Dr. Ashish had answered this question yesterday. Probably there is not much of such. Dr. Ashish, I think he is a better person to answer this question.
Okay, then I'll ask this question to him.
हेलो राजेश सर, डॉक्टर आशीष सर को माइक लगा दो.
Can somebody give mic to Dr. Ashish Tandon?
Hello.
Dr. Ashish. There is a question for you, boss. Is there any experience of doing this surgery post injection? As there are reports of high scarring and dural tears post injection.
Which surgery are you talking about?
Disc surgery, discectomy surgery.
Yeah. I have. I mean, plenty of cases. Tubular में तो there is very good number, and now in interlaminar pure endoscopic also, I have had around 4 to 5 cases over last 8 to 9 months in which I have found particulate steroid. But we are able to negotiate.
Your voice is not audible, Dr. Ashish.
How is it now?
Yeah, it's better now.
So what I'm saying is, last 8 to 9 months, I have had around 4 to 5 cases in which on endoscopy, I have been able to locate depots of steroid, but as such, I did not find extensive scarring as such.
Okay.
Yeah, and for tubulars, like when we do tubular discectomies, there's quite often that we find that there are steroid particles.
Can we expect granuloma formation if we leave them for some more time? Granular formation in these cases? Some sort of granuloma?
No, Rajiv, I have not had a situation like this.
Okay.
एक मिनट सियाम लाएंगे. So can we get the history again? Okay. And any history of headaches? Okay. So what we elicited was that the patient has, lot of vague symptoms as well. She has pain going up to the posterior aspect of the head, in the shoulder areas, and she's not very specific in terms of her pain, especially in the limbs. At times she'll say that she has more on the right and then on the left side. So our decision is just to go for a plain, simple epidural block. Okay, can I get a pillow, please? हाँ, ये भी चलेगा. Can somebody come on that side? मैडम आपको ये पेट उठाना पड़ेगा, हमको ये नीचे डालना है. You pull it.
You want to give some tilt or what, Dr. Ashish, by putting a pillow beneath?
No, just want to open because I find that, matlab, clinically I have a sense that इसमें interlaminar space may be a little jeopardized.
Okay.
थोड़ा नीचे लाएंगे. So the plan is to do a L5S1 epidural.
What about Wilson frame? If at all you want to open up the spaces, will Wilson frame will be a better option?
A patient is very uncomfortable when the patient is
Conscious.
not anesthetized.
Okay.
And also I feel that AP may, until unless you have a totally fluoro-negative radiolucent frame, then it is different. But otherwise you need AP lateral shot, so it may just hamper a bit. चलो, can I get a needle or something? Mark करने के लिए? नहीं, a bigger one. And a marker pen, please. I hope the blood pressure is okay, right? It's very high. Can you give something for blood pressure? हाँ. ठीक है, ठीक है. थोड़ा सा अपने तरफ लीजिए. हाँ, और लीजिए. मैडम आप ऐसे हो जाएं, बस. चलो शूट करो. ओके. So it is centralized. अभी tilt करिएगा please. ऐसा ऐसे देखिए, ऐसे tilt कीजिए. हाँ, करिए. बस. शॉट लीजिए. ओके, नीचे ले जाइए. पाँव की तरफ. ओके, गुड. अभी शूट. थोड़ा सा और टिल्ट कीजिए, हल्का सा और. हाँ, अभी शूट कीजिए. It's better. Let's see. Shoot, please. Shoot, please. Shoot, please. Okay, I think this should be good. Marker pen, please. एक मिनट, थोड़ा सा और टिल्ट करना. आई एम नॉट वेरी हैप्पी एज सच. थोड़ा और टिल्ट करके दिखाना. और करो. हाँ, अभी दिखाना. हाँ, now it is better. और थोड़ा टिल्ट कीजिए. हाँ, शूट कीजिए. Okay, better, नहीं? Pedicles, we can see the pedicles much better now. Let's see अभी location. Shoot करिए. Okay, अभी. Okay. So let's go a little higher. Local, please. Local लगा दे. And थोड़ा बीटाडीन लगा दे. मैं आता हूँ. हाँ, लगा दो. Local लगा देना Xylocaine. ऊपर वाला है. पूरा एरिया ही इन्फिल्ट्रेट कर देना.
I'm reminding everybody to fill in the feedback forms which have been posted to the group, because we would appreciate your feedback. And also, as told earlier, there's a vertebroplasty hands-on in the Synthesis stall. Whoever's interested can go there.
वो जो वो आएगा ना लिगामेंटम फ्लेवम तब मैं तुमको दूंगा. Okay, can I have a shot, please? So, are you there with us?
Yes, yes, we are there.
Okay, so we are just about starting epidural block.
This is at what level?
L5S1.
Okay.
Shoot, please. Tilt कीजिए. एक मिनट हाँ. Shoot कीजिए. Okay. Good. Okay, at this point तुम्हें you will start feeling a gritty सा sensation. So just go millimeter by millimeter, feeling a gritty sensation.
Ashish, you are exactly in the midline, and you are going in the interspinous
Yes.
space.
Yeah. ज़्यादा deep.
Any local anesthesia you have given in this area?
Yeah, we have already given local.
Till what depth?
Till the whole depth of the needle, the
1.5 inch.
Yeah.
Okay.
बस एक बार shot ले लीजिए. हाथ अलग करो. हाँ, एक shot और लीजिए. Okay. So एक मिनट दिखा. Now मेरे को वो चाहिए रहेगा. हाँ है अभी भी है. So at this point of time there is, I'm very sure there will be resistance है, ठीक है? नहीं अभी नहीं हाँ अभी धीरे धीरे डालना है. And then एक थोड़ा सा patient भी wince करेगी, हल्का सा pain आएगा उसको, and you will also feel a sudden resistance giving way. Go slow. हाँ मिला. Yeah. And she also, she gave a small cry, and let's confirm. So there's loss of resistance. Lateral कर लीजिए. But we can be, it's always better to be sure on AP and lateral. हाँ या टेबल हाइट अप कर लीजिए.
So, Dr. Ashish?
Yeah.
Yeah, yesterday we were doing L4, L5, so probably L5S1 is a bit easier to push than ready because of the larger space.
Yeah. करना और और तुम नीचे कर लो ना अगर जा, हाँ चलो आप कर लो और कर लो. Okay, thanks. Okay. So, still it then हम एक मिनट ये resistance वाला thing please. Yeah, we are not getting any resistance. So die है. Let's see. Shoot please. Yeah, the epidural is going down, inferior, ऊपर कम जा रहा है, but inferior we have got.
See the tip of the needle is pointing upwards.
Bevel is pointing downwards.
Yes.
No, in this case, see, please don't go by the, generally by the, just by the Siam, because if it is right or left also, you may get it as
Right.
up
Understood.
or down, yeah.
Yes.
But now we can see the epidural dye going up as well.
Yes.
So, sensor can, Bupiva can.
So Ashish, do you also put saline, hypotonic saline or anything else?
No, generally not. What I do is, if I want extra amount,
Yes.
I would just dilute my bupivacaine with the saline.
Right.
So I don't sort of create space first. I just use saline mixed with diluted bupivacaine and I inject.
Right. And what about steroids? You will do after that.
Matlab, we'll first put the bupivacaine and the same thing that we did yesterday.
Yes,
yeah.
yes. Okay.
So basically, Deepak, it's just you. The drugs that you're doing is same. It is just where you're positioning the needle for different things.
Correct, correct.
Yeah. We'll put 1.5. Okay, Dexa, please. 4. Okay, previously I used to put, but now I've sort of stopped it. Also in endoscopic, because almost I'm using 4 to 6, 8 liters of saline, which is washing it out. So, and there's a lot of saline already inside while I'm doing the surgery, even when I'm taking out the cannula. So practically I don't think so there's a lot of role of steroid. Since bupivacaine. We are through. Yeah. ले सकते हैं.
Also, do you need to put in a catheter and take it upwards, Ashish?
I mean, if you want to push in drugs at multiple levels,
Yes.
only in that case, because I just want to draw your attention to the right side film. Can you see the right side? See, the dye has reached almost L4-5 ka top part of the
Yes,
foramen.
yes, we can see that.
Yeah, so when I'm injecting, the drug is also going to go there.
Right.
But suppose if I want L3 tak jaye, to then I may have to push in a
Correct.
catheter. Yeah.
So is it over the procedure?
Yeah, the procedure is done.
So I have sent Rajiv to be there with you for the last case. There is one more case apparently.
Acha.
So you and Rajiv can do that.
Yeah, sure, no issue. But what is the case?
That is surprise. Again, I think a lumbar case.
Acha.
So maybe simultaneously we'll shift to OT2. Is it been taken in OT2? Anuj, any case been taken up in OT2?
नहीं, ऐसे नहीं. Tilt करो.
एक मिनट रुको.
पेशेंट नहीं दिया. हाँ, तो शिफ्ट टू OT2.
Yes, sir.
Ashish, you will be required to go to OT2 then, I think.
Yes, sir. OT2, you are connected.
Okay, we are in OT. हेलो हाँ हाँ डेमो करा दो, कोई प्रॉब्लम नहीं है। हाँ हाँ। So apparently they have a shift to OT1. They have a case, another cervical waiting. Maybe they can finish that also. OT1 में shift करो. So Ashish, can we have the mic on Ashish?
Okay, sir.
हाँ वो तो पुरानी बात है, कब की बात है? अच्छा 4-6 यू आर इंटरेस्टेड? डेमो करा दें? पहले डेमो कर स्टेटस में बस तो ठीक है। और अभी उन्होंने प्राइसेस चेकअप कर दिए, बहुत महंगा पड़ा, 4-5 लाख का, बट स्टिल डेमो कर दो, यू आर 100% कॉन्फिडेंट? हाँ हाँ अभी आई एम कॉन्फिडेंट, ये नया मशीन बड़ी सी बना दी उन्होंने। नहीं नहीं आई एम कॉन्फिडेंट। हाँ 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 आई एम कॉन्फिडेंट अबाउट द न्यू। तो आपको एक बार फिर डेमो करो, मैं पता करता हूँ। मैं पता करके NSI वो पुराना वो मॉडल नहीं कर पाया, पर मैं जो भी डिस्ट्रीब्यूटर हो So what has been decided is apparently he's just delivered the message that after Ashish Tandon talked to the patient, they feel it was better served by medication than by giving a block. So they have cancelled that case. So this is so Ashish Tandon will come and we'll have a discussion. But I think the patient is foremost. For whatever reason, it's not that we should unnecessarily do any procedure when it can be managed by a procedure or a medicine which is one level lower than that. ट्रस्ट चल रहा था उसमें ट्रांसमिशन तमाम लोगों ने मैसअप कर दिया ट्रांसमिशन नहीं है उसमें उसका पता करो माइक्रोस्कोप है connected. We actually have a third case going on for dresotomy, but unfortunately the transmission is not there for that OT. So we are seeing if we can show, then I will show that final dress procedure to you. If microscope, even the transmission from microscope is available, then we'll be able to show. So if we have this workshop next time, I would like to know what other procedures would any of you like to see besides the one we have already shown. Have you got any other wish list? Sorry? Neurectomies you would like to see, okay. Oh, okay. Carpal tunnel, actually, Dr. Sharat Chandra, one of the unit heads, he's also devised innovated a device for minimally invasive. So that is okay. I understood carpal tunnel and coccydynia. Brachial plexus, what? Neurotizations. Okay. That we have a separate, conference. That itself is we have the annual conference of brachial plexus surgery in January in AIMS Raipur next year. So that is, we have that already going on. But for pain procedures, anything else? Spinal cord stenosis. Yes, we had thought that we might have, but we didn't have an appropriate case this time. So, Ashish, please come here. So I will keep that in mind next time when we'll have, besides these procedures. So, first of all, I thank Dr. Ashish for a beautiful demonstration, especially a neurosurgical perspective, because there are so many neurosurgeons here, and we are not basically doing justice for these kind of patients. And this is the very, I would say, low hanging fruit for a neurosurgeon in terms of relieving pain. And especially, I think in institutions like ours and AIMS, where we have these patients whom we give date for surgery, and we have a waiting list of 2 years, 3 years for this surgeries. So in the interim, all these procedures can be really nice. Also for trigeminal neuralgia, because when we give a date for MBD, they get admitted after a year or so. So it might happen that most of these patients may not require surgery when they come after a year or two. Anyway, all randomized studies have shown that for any disc pain, if you do anything, at the end of 2 years, he will be better. So if we give these pain procedures, everything is based on the acute treatment of pain. So I think we have learnt a lot from both Dr. Dureja and Dr. Ashish, and we have got two perspectives. It's very important to have a different perspective so that you can have a balanced view and decide what you would like to do in your own practice. You can see the pros and cons of everything. And I think, especially for trigeminal neuralgia, we heard his Dr. Ashish's perspective that why he likes sedation, and I would agree with him, because we all have a learning curve, and when we are doing this, we might, if the patient is screaming and turning around on the table, it makes life difficult. So if we have sedation available, it makes it very easy, and we are all already so used to doing everything under anesthesia that it will take us a little bit of time to go on to completely local, whatever you call it. So, Ashish, your comments on, we would like your views that you have been doing. Ashish is an alumni from AIMS only. We are almost batchmates, and it's been, I think, 18 to 19 years that he has been in practice. So, his journey, obviously, he does a lot of endoscopies, as you must have heard on his talks. But his journey as which transformed him into a pain specialist also during the last 2 decades.
Yeah, so basically, first I'll give you why I started RF. So I was trained under Professor Gentili and Professor Teo, and we used to do keyhole. I learned skull base and keyhole surgery for trigeminals and CP angles, etc., etc. But I never had patients. So I was just doing about 2 or 3 MBDs per year. And that was almost for 5-7 years. So I just asked myself that there's something wrong. There's so many trigeminals and they don't come to me. They come to me, consult, I advise them surgery, and I never see them back. And now I'm doing almost 1 to 3 RFs per month.
So if you look at my numbers, there is a huge shift over the years. And that is why I would request all of you to take up RFs or these procedures, because the patients agree pretty fast and you are not losing the patient, and that's the practical part. And the other thing is, if the results are very different, then you may think, okay, look, I am still with MVD. But if the results are so similar, then why not if the patient is agreeing to it? So that's for trigeminal. As far as see lumbar disc and lumbar pain and neck pain is concerned, one very important patient sort of pulled me into the pain practice. So there was a moderately large disc and the patient had EHL weakness. This was way back in 2008 or 9. And I told him that, look, you need surgery, you need urgent surgery, and we don't have anything else. 15 days back, he comes to me that I'm absolutely fine and I have no pain and I have got my sister for headache. So it was such a major shock for me that I am pushing for surgery and he comes to me and tells me that in 15 days he has been fine and he received a block. So that sort of jolted me and told me that I need to change something in my practice. And then obviously we should have all the weaponaries with us. If we are not ready for that, especially in private practice, then you are missing a lot. And so if you're doing 30 to 40 cases a month or 50 cases a month, and if you're losing 2 or 3 patients, that means you're losing almost 10% of your patient load. So you need to expand your repertoire. That's what I feel. The second aspect which I tried to push in these 2 days is getting young people to do and show to all of you that you can very easily go back and do it. If I can do, if Rajiv can do, if Datta can do, then all of us can do. And we have a much better anatomical perspective because we are also going inside looking at the anatomy. So that 3D vision जो हमारा बन जाता है, that is much better, I feel. So I would urge all of you to, get into it, and I hope we are able to take our neurosurgical field to higher levels. Also, I would like to present my extreme thanks to Rajiv, Deepak, and the whole team for inviting me. It has been an honor coming back. It's like a dream coming back to your alma mater and going to the same theaters, meeting the staff. So I am extremely obliged. Thank you so much.
Good afternoon, everyone. With this, we conclude our sessions for the day today. And as today's day was only half day, so with this we'll complete our workshop proceedings. And the summary of this workshop, which I could make out from my mind, is it might be different from for everyone, but for my mind is as a clinician, as a pain, I think everybody is a pain specialist because at least 70% of everyone's patient is related to some sort of pain. So that's why we all should have some good idea, not some idea. We should have good idea about pain. And as we are all a significant number of us amongst us are neurosurgeons, so these are all good practices. We should expand our armamentarium as Dr. Tandon has just highlighted to us. So with this, we conclude the proceedings of the workshop, and I am very thankful to you for coming so far off, leaving your work, your practice for not 2-3 days, coming and going, including and contributing significantly to this workshop. Your feedback will be very important to us. So I request you all to, as early as possible, please send us the feedback. And with this, thank you very much from bottom of our heart. The whole team of ISPNS and including President Dr. Indra Devi, Secretary Dr. Deepak Agrawal, and the whole ISPNS team, thank you very thank you much. And we will invite you further for such whenever we organize such conferences in future. Thank you very much. And we all can have lunch. Lunch is ready. We can have lunch outside in the dining hall. Thank you very much.